Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
In medical toxicology, the process of decontamination aims to limit the absorption of xenobiotics that can be ingested, inhaled, come into contact with the skin, or affect the eyes. This field is characterized by ongoing debate and a notable shift towards less aggressive interventions in treatment protocols. Therefore, a thoughtful and evidence-based approach is essential for effective management. Decision-making regarding decontamination must take into account various factors, such as the specific toxin involved, the clinical condition of the patient, and the potential risks and benefits associated with each available decontamination method. It is important to avoid routine or instinctive administration of decontamination, as this practice is strongly discouraged. Instead, seeking expert consultation with medical toxicologists can be instrumental in developing treatment plans that are directed toward specific goals, ensuring that the most suitable interventions are employed for each individual case. The 10 learning objectives based on the provided content are essential for understanding the complexities of decontamination in medical toxicology. First, it is crucial to grasp the primary goal of decontamination in this field. Additionally, one should be able to identify the 4 main routes of exposure to xenobiotics, as these situations are where decontamination strategies may be necessary. It is important to recognize that the strategies for decontamination in medical toxicology are continuously evolving and often subject to debate. A deeper understanding of how activated charcoal functions in limiting toxin absorption is also vital. Furthermore, various factors can influence the effectiveness of activated charcoal as a decontaminant, and knowing these factors will enhance your approach to treatment. There are common situations in which single-dose activated charcoal may be used. However, it is equally important to understand when its application is relatively contraindicated. In some cases, multiple-dose activated charcoal can be rationalized for certain poisonings, and this is a critical consideration in the treatment process. Another aspect to cover is the principle of whole bowel irrigation, which should be described alongside typical scenarios that might necessitate its use. When dealing with different types of exposures, dermal, ophthalmic, and inhalational, knowing the initial steps for effective decontamination is imperative. Lastly, one must recognize the importance of considering the specific properties and pharmacokinetics of ingested substances when planning any decontamination strategy. In the field of medical toxicology, managing patients who have been poisoned often requires interventions designed to limit the absorption of harmful substances, a process known as decontamination. However, this area of toxicology is marked by ongoing debate and a gradual move away from routine and aggressive interventions. It is crucial to adopt a careful, evidence-based strategy that takes into account the specific toxin involved, the clinical presentation of the patient, and the potential risks and benefits of each treatment option. Gastrointestinal decontamination, which includes various techniques to prevent the absorption of toxins ingested orally, has traditionally been a fundamental aspect of the initial management of poisoned individuals. Nevertheless, the effectiveness of these decontamination methods in enhancing significant clinical outcomes, such as reducing mortality rates, remains contentious. This uncertainty arises from the challenges of conducting rigorous clinical trials within this diverse patient population. Factors that complicate the situation include many unreliable patient histories and low-risk exposures, which hinder the ability to demonstrate a distinct advantage in using these methods. Therefore, administrators shouldn't use decontamination interventions as an automatic response. Instead, evaluating the toxicity of the substance involved is essential, assessing the possible benefits of decontamination, and considering the risks associated with the intervention. In instances where large amounts of highly toxic substances have been ingested, however, decontamination could be a critical measure to save the patient's life. The debate concerning gastrointestinal decontamination reached a peak in 1997 with the release of position statements on various methods by the American Academy of Clinical Toxicology and the European Association of Poison Centers and Clinical Toxicologists. These methods included activated charcoal, orogastric lavage, syrup of ipecac, and whole bowel irrigation. Over time, revisions to these guidelines have generally shifted toward less aggressive treatment approaches. Despite these consensus recommendations, there remains significant variability in the guidance provided by poison specialists. This variability underscores the fact that existing studies and guidelines may not be applicable to every case, particularly those involving atypical or severely poisoned patients. This situation creates uncertainty when it comes to selecting the best gastrointestinal decontamination strategy. Interestingly, only one study has shown a survival advantage linked to any form of gastrointestinal decontamination. This suggests that the lack of observed benefit in many studies may arise from the application of these procedures to patients who would have experienced favorable outcomes even without any intervention. Consulting with experts in clinical and medical toxicology can assist in assessing risks and in formulating treatment plans that are directed toward specific goals. Activated charcoal is a critical component of gastrointestinal decontamination in toxicology. It is often used to limit the systemic absorption of ingested toxins. The effectiveness of activated charcoal arises from its large surface area, which enables it to absorb a wide range of drugs and poisons within the gastrointestinal tract. This process effectively reduces the bioavailability of these harmful substances. In this chapter, we will focus on the appropriate timing for gastrointestinal decontamination and the preferred techniques to use once an indication for treatment has been established. Activated charcoal is created by the controlled process of pyrolysis, which involves heating carbon-based materials such as coconut shells or peat. Following this, an activation process is conducted using high-temperature gases or chemical treatments. As a result of these processes, a highly porous form of carbon is produced, which has an exceptionally large surface area that can reach up to 3,500 square meters per gram. This unique structure allows for significant adsorption of various substances. Adsorption takes place through weak intermolecular forces. Generally, non-ionized organic compounds bind to activated charcoal more effectively than dissociated inorganic ones. The atomic structure of activated charcoal is characterized by a combination of pentagonal and hexagonal configurations. The process of adsorbing a xenobiotic by activated charcoal is complex and depends on various weak intermolecular forces. These forces include hydrogen bonding, ion-ion interactions, dipole forces, and van der Waals forces. Activated charcoal is most effective at adsorbing xenobiotics when they are in their dissolved non-ionized forms. This is because non-ionized organic compounds tend to bind more strongly to activated charcoal than do dissociated inorganic substances. The physical and chemical characteristics of xenobiotics significantly influence their adsorption. Compounds with moderate molecular weights, specifically those ranging from 100 to 800 daltons, generally show good adsorption to the pore sizes found in contemporary activated charcoal products, which are typically between 10 and 20 angstroms. Additionally, mesoporous charcoals, which have larger pore sizes of 20 to 200 angstroms, can effectively adsorb larger xenobiotic molecules. However, there are some substances that do not bind well to single-dose activated charcoal under ideal conditions. For instance, metals, especially salts of iron and lithium, hydrocarbons, and caustics do not adhere well. Although activated charcoal can adsorb toxic alcohols such as methanol and ethylene glycol, as well as cyanide, its clinical utility may be limited owing to unfavorable stoichiometric ratios. The properties of activated charcoal are not uniform, and these physical attributes have a significant impact on its adsorptive capacity. The activation process, which usually involves treating the charcoal with gases at high temperatures, removes previously adsorbed substances and further reduces the particle size. This process produces an exceptionally porous final product, creating an internal maze of pores that significantly increases the surface area available for adsorption. The average surface area of activated charcoal typically ranges between 800 and 1,200 square meters per gram, with some superactivated charcoal preparations boasting up to 3,500 square meters per gram. This vast surface area is the primary reason for the high adsorptive capability of activated charcoal. To put this into perspective, a standard 50-gram dose of charcoal can possess a total surface area comparable to about 12 American football fields. The rate of adsorption is influenced by the external surface area, while the total adsorptive capacity is determined by the larger internal surface area created by the pores within the charcoal. The distribution of pore sizes within activated charcoal is also crucial. Most current activated charcoal products have pore sizes ranging from 10 to 1,000 angstroms. The majority of the internal surface area is produced by pores in the 10 to 20 angstrom range, which are particularly effective for adsorbing most xenobiotics with moderate molecular weights. Since activated charcoal adsorbs drugs and other xenobiotics through binding, there exists a stoichiometric relationship where a higher ratio of charcoal to drug more effectively inhibits systemic absorption. For example, a 50-gram dose of activated charcoal would likely be more effective at preventing the absorption of 3 grams of amitriptyline than 30 grams of valproic acid. While a ratio of 10 parts activated charcoal to 1 part drug has often been suggested, some experts recommend that a ratio of perhaps 40 parts to 1 may provide superior adsorption results. This underscores the necessity of considering the quantity of the ingested substance in relation to the administered dose of activated charcoal. The timing of activated charcoal administration significantly impacts its effectiveness as a method for gastrointestinal decontamination. Like many decontamination techniques, the efficacy of single-dose activated charcoal diminishes over time after ingestion. Research involving human volunteers has shown that activated charcoal is more likely to be beneficial if administered within the first hour following ingestion. Meta-analyses from these trials indicate that single-dose activated charcoal reduces the area under the concentration time curve for up to 4 hours after ingestion, although the magnitude of this effect diminishes over time. Delayed administration may lead to reduced efficacy, as the xenobiotic is absorbed into systemic circulation before the charcoal can act. The presence of other substances within the gastrointestinal tract may also interfere with the adsorption of xenobiotics by activated charcoal. For instance, the antidotal efficacy of activated charcoal can be compromised by thickening agents. Studies have further investigated whether food items such as jam, starch, and milk can diminish the adsorption of toxins by activated charcoal. Additionally, the palatability of activated charcoal is a consideration, especially for pediatric patients. Consequently, flavoring agents have been tested to improve its acceptance. It is crucial, however, to ensure that any additives do not significantly reduce the adsorptive capacity of the charcoal. Moreover, the transit time of activated charcoal through the gastrointestinal tract can be affected by various factors. These factors include the type and amount of ingested xenobiotic, the patient's fasting and hydration status, perfusion, and the use of associated cathartics or evacuants. In conclusion, the adsorption of xenobiotics by activated charcoal is influenced by a multitude of factors. These factors include the properties of the xenobiotic, such as its ionization state and molecular weight, the characteristics of the activated charcoal, like surface area and pore size, the ratio of charcoal to the ingested substance, the time elapsed since ingestion, and the composition of the gastrointestinal contents. A thorough understanding of these elements is essential for clinicians to appropriately evaluate the potential benefits of activated charcoal in managing acute poisonings. The decision to administer activated charcoal, whether as a single dose or multiple doses, should always be grounded in a careful assessment of risks and benefits, taking into account these adsorption factors alongside the specific clinical context. Although it is not generally advisable to use single-dose activated charcoal routinely, it may be considered in specific cases. For instance, if a patient has ingested a substance that is known to be adsorbed by activated charcoal, and this ingestion occurred within a reasonable time frame, the use of activated charcoal might be appropriate. This time frame is often suggested to be within 1 to 2 hours. However, for certain drugs or sustained-release formulations, this time frame may extend beyond 2 hours. The decision to use activated charcoal should be made after conducting a risk-benefit assessment. Factors that may support the use of activated charcoal include the potential for significant toxicity from the ingested substance and the patient's capacity to tolerate and retain the charcoal. There are several relative contraindications to the use of sodium decontamination and absorbent carbon SDAC when treating patients. First, an unprotected airway poses a significant risk. The risk of aspiration increases in patients who have a decreased level of consciousness or an impaired gag reflex unless the airway is secured. Additionally, the ingestion of substances that are poorly adsorbed by activated charcoal is problematic. This category includes most metals, alcohols, hydrocarbons, and corrosive substances. Other clinical conditions that could worsen with vomiting or aspiration should also be considered. For example, patients who have recently undergone esophageal or gastric surgery are at an increased risk. Furthermore, any existing intestinal obstruction or perforation must be taken into account. A table in one source likely provides a detailed outline of specific indications and contraindications related to the use of this treatment. Although generally considered safe, activated charcoal is not free from risks. The most frequently observed adverse effects include vomiting, which can lead to aspiration pneumonitis. However, a comprehensive study of patients who overdose found that the use of standard doses of activated charcoal, SDAC, was not a risk factor for aspiration pneumonitis. Instead, a decreased level of consciousness was identified as a contributing predictor to this condition. Despite this, aspiration of activated charcoal can result in severe complications such as rapid-onset adult respiratory distress syndrome and chronic lung disease. Cases of activated charcoal laryngitis have also been documented. Therefore, the risk of aspiration must be carefully evaluated, particularly in patients with altered mental status. Other possible complications associated with activated charcoal include the formation of bezoars, which can cause bowel obstruction, especially after multiple doses. Additionally, the use of sorbitol as a cathartic alongside activated charcoal raises concerns due to the potential for dehydration and imbalances in electrolytes, particularly hypernatremia, in children. Multiple-dose activated charcoal involves the repeated administration of activated charcoal to enhance the elimination of certain drugs. These drugs may undergo enterohepatic or enteroenteric recirculation or exhibit prolonged absorption. By adsorbing the drugs secreted into the intestine, multiple-dose activated charcoal can increase its overall clearance from the body. Medications that have been considered for this treatment include theophylline, phenobarbital, and carbamazepine, although it should be noted that this method does not enhance the excretion of all drugs. The American Academy of Clinical Toxicology and the European Association of Poison Centers and Clinical Toxicologists have published position statements and practice guidelines regarding the use of multiple-dose activated charcoal. Several factors can influence the effectiveness of activated charcoal. The time since ingestion is an important consideration, as efficacy generally decreases with time as more of the toxin is absorbed. The dosage of activated charcoal is also crucial. A sufficient dose relative to the amount of ingested toxin is necessary for optimal adsorption. For instance, a dose-dependent adsorptive capacity has been demonstrated for paracetamol. The physicochemical properties of the toxin further impact activated charcoal's efficacy. Activated charcoal adsorbs certain substances better than others, with non-ionized and lipophilic drugs tending to bind more readily. Additionally, the presence of gastric contents can reduce the effectiveness of charcoal. Food in the stomach may compete for binding sites or delay contact with the toxin. Research has investigated the effects of various substances like jam, starch, and milk on activated charcoal's antidotal efficacy. Different formulations of activated charcoal may exhibit varying adsorptive capacities. The palatability of various charcoal mixtures, including flavored versions, has also been studied, particularly in pediatric patients. Lastly, there are concerns that whole bowel irrigation may decrease the efficacy of activated charcoal for certain drugs. The role of activated charcoal is often considered alongside other gastrointestinal decontamination techniques, such as orogastric lavage and whole bowel irrigation. Current medical guidelines typically do not recommend routine gastric lavage. Activated charcoal is frequently preferred due to its ability to adsorb a wider range of toxins. In situations where both activated charcoal and lavage are considered, activated charcoal is usually administered after the lavage procedure. Whole bowel irrigation is utilized for substances that are poorly absorbed by activated charcoal, including heavy metals and sustained-release formulations, as well as for body packers. There are concerns regarding the potential desorption of drugs from activated charcoal when polyethylene glycol electrolyte lavage solution, used for whole bowel irrigation, is present. Consequently, the sequencing and combination of these methods require careful consideration. Regarding the administration of activated charcoal in a pre-hospital setting, studies have explored its feasibility as a means to reduce the time to administration. Earlier administration, which occurs closer to the time of ingestion, is generally believed to improve its effectiveness. Activated charcoal has a long history of use in managing acute poisonings, yet its optimal role remains a topic of debate. Some experts advocate for a selective approach that considers the specific substance ingested, the clinical presentation, and the time elapsed since ingestion. Others highlight the potential benefits of activated charcoal, particularly when it is administered early in the process. It is not uncommon for discrepancies to arise in the guidance provided by poison centers regarding its application. In clinical practice, activated charcoal is recognized as a valuable tool in the initial management of oral poisonings. It primarily works by preventing the gastrointestinal absorption of a variety of toxins. Although the evidence from rigorous clinical trials is still developing, pharmacokinetic data and clinical experience increasingly support its use, especially when given shortly after the ingestion of a substance that can be adsorbed. Therefore, the decision to use activated charcoal, whether as a single dose or in multiple doses, must be made with careful consideration of the potential benefits and risks specific to each poisoning case and the individual patient situation. Its role is integrated within a broader framework of toxicology and decontamination, requiring a thoughtful combination with other supportive measures and gastrointestinal decontamination techniques, which should be guided by evolving evidence and expert consensus. In the field of toxicology and decontamination, intestinal evacuants serve as interventions designed to minimize systemic exposure to ingested foreign substances by facilitating their removal from the gastrointestinal tract. This method aims to alter the pathway of a toxin within the body, primarily by reducing the time it takes for substances to transit through the gastrointestinal system and by enhancing the evacuation of waste through the rectum. There are several substances that can promote intestinal evacuation, but the most widely used technique in medical toxicology is whole bowel irrigation. This is typically accomplished through the administration of a balanced polyethylene glycol electrolyte lavage solution, commonly referred to as PGLS. Intestinal evacuants can be categorized based on their sources, using various terms such as laxatives, cathartics, purgatives, promotility agents, and evacuants. The effectiveness of these substances often varies depending on the dose administered, with different side effect profiles associated with each category. Laxatives, for example, can be further divided into several types. These include bulk-forming laxatives like methylcellulose and psyllium, softener or emollient types such as docusate calcium, and lubricants like mineral oil. Stimulant or irritant laxatives include senicides, bisacodyl, and castor oil, while saline options include magnesium citrate and sodium phosphate. Hyperosmotic laxatives encompass substances like sorbitol and lactulose. However, it should be noted that bulk-forming, softer, and lubricant laxatives are generally not used therapeutically in medical toxicology due to their delayed onset of action. Furthermore, saline and hyperosmotic cathartics are used less frequently in cases involving poisonings. The method of whole bowel irrigation using PGLS remains the most common and thoroughly studied approach to intestinal evacuation in this medical context. Whole bowl irrigation is a procedure that involves either oral or nasogastric administration of large volumes of a non-absorbable, osmotically balanced polyethylene glycol electrolyte lavage solution. This is done to swiftly clear the gastrointestinal tract and prevent the further absorption of ingested toxins, with the goal of achieving complete gut clearance within a few hours. PGLS is considered osmotically inactive, meaning it minimizes the absorption or secretion of water and electrolytes across the intestinal lining. Whole bowel irrigation has proven safe in various patient populations, including children, adults, and pregnant women. Initially developed for bowel preparation before surgery or colonoscopy, the technique of using a balanced electrolyte solution for whole bowel irrigation emerged later for toxicological applications. Early reports from the 1970s documented its use in cases of lead pellet ingestion that did not respond to other treatment methods. The main pharmacologic effect of whole bowel irrigation is the mechanical flushing of the gastrointestinal tract. The large volume of non-absorbable fluid pushes the ingested substance through the intestines, thereby reducing the time available for absorption. The balanced electrolyte composition of PGLS helps prevent significant fluid and electrolyte imbalances during this process. The American Academy of Clinical Toxicology and the European Association of Poison Centers and Clinical Toxicologists have published position statements on whole bowel irrigation. These guidelines suggest that whole bowel irrigation may be reasonable for potentially toxic ingestions of specific substances. Modified-release pharmaceuticals can remain in the gastrointestinal tract for prolonged periods. Whole bowel irrigation can help remove these formulations before complete absorption occurs. Substantial amounts of metals such as iron, lead, and lithium are poorly absorbed by activated charcoal, making whole bowel irrigation a more suitable decontamination method. This approach has been evaluated for overdoses of iron, lead, lithium, and zinc. In cases involving large amounts of xenobiotics with a slow absorptive phase and the potential for high morbidity, the extended time window allows for possible benefits from whole bowel irrigation. Lithium is again frequently mentioned in this context. Additionally, when xenobiotics are not adsorbed by activated charcoal, whole bowel irrigation may be considered if the substance poses a significant risk. Another indication for whole bowel irrigation is the removal of packets of drugs that individuals, referred to as body packers, may conceal. This unique application facilitates the elimination of these drug packets. It is noteworthy that when activated charcoal is anticipated to be beneficial, it is generally recommended to administer it before initiating whole bowel irrigation to maximize its adsorptive effects. However, concerns exist regarding the potential for polyethylene glycol electrolyte solutions to cause desorption of drugs already bound to activated charcoal. Studies have investigated this potential interaction in vitro for substances like fluoxetine and cocaine, revealing that polyethylene glycol electrolyte solutions could reduce the adsorption capacity of activated charcoal. WBI should not be safely applied to patients who do not have an intact gastrointestinal tract. The presence of an adynamic or obstructive ileus is another contraindication. In addition, significant gastrointestinal hemorrhage is a crucial reason to avoid this treatment. If a patient has inadequate airway protection or is experiencing uncontrolled vomiting, the usage of WBI poses a heightened risk of aspiration due to the large volumes involved. Furthermore, hemodynamic instability that compromises gastrointestinal function or leads to prompt oropharyngeal reflux makes the application of WBI unsafe. Caution should also be exercised with patients who have undergone bariatric surgery. In this population, activated charcoal has been used more frequently compared to whole bowel irrigation and orogastric lavage. The role of whole bowel irrigation must be considered within the broader context of gastrointestinal decontamination, which includes techniques such as orogastric lavage and activated charcoal. In recent years, medical toxicology has shifted towards less aggressive gastrointestinal decontamination approaches, reflected in updated position statements that emphasize a more selective application of these methods. Orogastric lavage is generally not recommended on a routine basis due to the limited evidence of its clinical effectiveness and the potential risks involved. This method, which aims to remove xenobiotics before absorption, has been shown in studies to produce modest, varied, and unreliable effects. Conversely, activated charcoal is often the preferred option due to its broader absorption spectrum. Typically, activated charcoal would be administered after orogastric lavage in instances where both decontamination methods are deemed appropriate. As previously discussed, the combination of activated charcoal and whole bowel irrigation must be approached with caution due to the potential for desorption. The usual sequence of administration involves administering activated charcoal first, followed by whole bowel irrigation if both treatments are considered necessary for the specific ingestion scenario. The evidence and controversies surrounding whole bowel irrigation are similar to those encountered with other gastrointestinal decontamination methods. Robust clinical outcome studies clearly demonstrating the benefits of whole bowel irrigation are scarce. The diversity of poison patients, along with the ethical challenges associated with randomizing individuals to either receive or not receive a potentially beneficial treatment, contributes to the lack of high-level evidence. Much of the support for whole bowel irrigation stems from experimental studies, theoretical pharmacokinetic considerations, and anecdotal human experiences. A position statement regarding whole bowel irrigation acknowledged the absence of clinical outcome studies, which complicates the establishment of definitive evidence-based indications. Despite this gap, expert consensus endorses its application in certain specific scenarios as previously outlined. One source within this discourse humorously presents a perspective on whole bowel irrigation, highlighting the ongoing debates and uncertainties surrounding its utilization while acknowledging a theoretical foundation for its efficacy, namely the reduction of toxin absorption by rapidly expelling it from the gastrointestinal tract. Whole bowel irrigation utilizing polyethylene glycoelectrolyte solution is a gastrointestinal decontamination technique designed to prevent the absorption of ingested toxins through mechanical flushing of the gastrointestinal tract. It is primarily considered for substances that are poorly absorbed by activated charcoal, modified release formulations, large ingestions of slowly absorbed toxins with high morbidity, and the management of individuals who carry large quantities of substances within their bodies. Although clinical outcome data are limited, guidelines developed by experts support the selective use of this technique in these specific clinical settings. Deciding to implement whole bowel irrigation requires a thorough evaluation of the ingested substance, the patient's clinical condition, and potential contraindications. Moreover, its application should be integrated thoughtfully with other decontamination and supportive care measures within the broader context of toxicology. Decontamination principles extend beyond oral ingestion to include exposure through skin, eyes, and breathing. The primary goal is to limit or minimize exposure to harmful substances before they are absorbed into the body. This is achieved either through physical removal of the contaminants or by using chemical agents to neutralize them. In contrast to gastrointestinal decontamination, the initial assessment and management of patients with skin or lung exposure begin with ensuring healthcare personnel's safety through appropriate personal protective equipment. The key objectives are to prevent further absorption of the toxins in the patient, avoid secondary contamination of medical staff or equipment, and protect the healthcare facility from becoming contaminated. For skin exposures, it is crucial to remove contaminated clothing and jewelry immediately. This should be followed by thorough washing of the skin with water, soap and water, or a diluted hypochlorite solution. The promptness of decontamination is the most critical factor in mitigating both local and systemic toxicity. While dry decontamination methods, using adsorbents such as activated charcoal or specialized products, are available, these are particularly useful for localized exposure to specific agents like nerve agents. However, they are generally not preferred in hospital settings due to a lack of familiarity and the potential delays they can cause compared to more effective wet decontamination protocols. Extensive irrigation with water should begin as soon as possible, especially in cases of corrosive exposure, as it plays a vital role in limiting morbidity and improving patient outcomes. Ocular exposures require immediate and copious irrigation of the affected eye or eyes with water or an isotonic saline solution. It is essential to remove any solid or particulate matter promptly before beginning the irrigation process. The irrigation should continue for a sufficient duration to ensure that the irritant is completely removed. The Morgan lens is a commonly used device designed for ophthalmic decontamination, especially in cases involving chemical burns or irritants in the eye. Its primary function is to provide a constant flow of irrigating solution over the surface of the eye, which is crucial for diluting and washing away contaminants. The design of the lens ensures that the irrigating solution reaches all surfaces of the eye, including the cornea, conjunctiva, and fornices, effectively flushing out harmful substances. Additionally, the Morgan lens can be inserted relatively quickly and easily, allowing for immediate emergency decontamination. Patient comfort is another advantage of the Morgan lens. Unlike manual irrigation methods that require constant eyelid retraction, the Morgan lens allows the patient to mostly close their eyes during the decontamination process, making it a more comfortable experience. Moreover, this device is versatile and can be used for various types of ocular contamination, including chemical burns, thermal burns, and the removal of non-embedded foreign bodies. It is important to note that while the Morgan lens is excellent for irrigating the eye to remove contaminants, ophthalmic decontamination can also refer to the cleaning and sterilizing of ophthalmic instruments to prevent infection during surgical procedures. In this context, the Morgan lens would not be decontaminated as it is a single-use device. In summary, the Morgan lens is a valuable tool for the ophthalmic decontamination of harmful substances from the surface of the eye. Inhalational exposures necessitate the immediate removal of patients from contaminated environments to fresh air. The severity and pattern of injuries caused by inhaled irritant gases frequently correlate with their solubility in water. Gases that are highly soluble typically lead to immediate irritation of the upper respiratory tract. Therefore, ensuring prompt access to fresh air is crucial for mitigating the effects of these exposures. Medical toxicologists play a critical role in the evaluation and management of complex or uncertain cases of poisoning. They excel in investigating situations where a toxicological cause is suspected but not immediately evident, often posing the question, could this be due to a toxin? Given the extensive range of potential toxins, obtaining a comprehensive history is vital, and including collateral information when available is essential. Toxicologists possess the expertise to thoroughly explore these histories and perform the necessary investigative work to identify potential exposures. These exposures may include prescription medications from both domestic and foreign sources, over-the-counter drugs, herbal remedies, and dietary supplements. Several valuable resources exist to assist in diagnosing and managing emergencies related to toxicology. The Agency for Toxic Substances and Disease Registry offers information on numerous toxic substances. The American College of Medical Toxicology provides clinical toxicology resources, which include an antidote card. Credible Meds maintains a list of drugs known to prolong the QTC interval, which raises the risk of torsades de pointes. The Dietary Supplement Label Database aids in identifying ingredients in various supplements. LiverTox provides critical information regarding drugs that can cause liver injury. The Flockhart table serves as a drug interaction chart. ToxNet encompasses a suite of databases that feature information on esoteric toxins, as well as LactMed, which discusses drugs and their effects during lactation. The developmental toxicology literature presents a database focused on reproductive toxicology. Finally, Goldfrank's Toxicologic Emergencies is a comprehensive textbook detailing the subject of toxicology. Occupational toxicology is a vital subspecialty within the broader field of toxicology and decontamination, concentrating on the negative health impacts stemming from exposure to chemical, physical, or biological agents found in the workplace. These types of exposure can lead to serious illnesses and even fatalities, similar to outcomes seen in cases of intentional poisonings and drug overdoses. Despite this, the connection between an individual's occupation and their health issues may not be apparent if a detailed occupational history is not taken. Consequently, a crucial component of a medical toxicologist's methodology involves exploring possible toxicological causes, including workplace exposures, especially when a clear diagnosis is elusive. This investigation includes gathering thorough information about the current illness, the circumstances leading to symptoms, and specific job-related exposures. Occupational toxicology covers a diverse range of hazards and the toxicities that may result from them. Notably, the primary mode of exposure in occupational settings is inhalation, largely due to airborne toxicants. Though oral ingestion is less common in these environments, dermal absorption remains a significant concern for certain chemicals designated with a skin designation, as they can lead to systemic effects or toxicity upon skin contact. While accidental ingestion is unlikely to occur at work, inhalation and dermal exposure are critical issues that warrant attention. Individuals in various occupations may encounter a wide variety of toxic substances. Gaseous compounds are a common source of toxic inhalation injuries. These gases are distinguished into categories, including simple asphyxiants that displace oxygen, toxic or chemical asphyxiants that disrupt oxygen utilization, such as carbon monoxide and hydrogen sulfide, and irritant gases that cause direct injury to the respiratory tract, including hydrogen chloride, ammonia, sulfur dioxide, and phosgene. The extent and location of respiratory tract injuries often depend on the water solubility of these irritant gases. Metal exposure is another significant concern. For instance, welders can suffer acute tubular necrosis due to cadmium exposure, and welding galvanized metal can cause metal fume fever from zinc oxide fumes. Additional metals like arsenic, lead, and chromium also pose risks in occupational settings. Solvents and hydrocarbons, including halogenated hydrocarbons such as carbon tetrachloride and chloroform, are frequently encountered in workplaces like mechanics, degreasers, and dry cleaners. These solvents can result in severe liver damage, while toluene exposure can lead to acute kidney failure. Other chemical agents, such as isocyanates found in the polyurethane industry and among firefighters, are irritant gases associated with acute respiratory distress syndrome. Carbon disulfide, historically having high exposure levels in the rubber industry, has been connected to accelerated atherosclerosis, while pesticides are a significant concern for veterinarians and animal handlers. Occupational exposures can result in various target organ toxicities. The lungs may experience toxic inhalation injuries that range from immediate irritation to delayed lung damage, potentially leading to acute respiratory distress syndrome. Reactive airways dysfunction syndrome and bronchiolitis obliterans fibrosa are both possible sequelae of such exposures. The heart may also be affected, as certain toxins like carbon disulfide are notably associated with accelerated atherosclerosis. The liver is another organ at risk. Numerous workplace xenobiotics are processed by hepatic enzymes, which can lead to liver injury, particularly from halogenated hydrocarbons and specific solvents. \n. The kidneys are vulnerable as well. Substances such as toluene, particular halogenated compounds, and arsine gas can cause acute renal failure through processes related to hemolysis. Additionally, occupational neurotoxicology impacts both the central and peripheral nervous systems, with examples of neurobehavioral abnormalities linked to high levels of carbon disulfide exposure. The hematopoietic system can be affected as well, with specific chemicals causing methemoglobinemia, hemolysis, and conditions such as aplastic anemia. A well-documented occupational history is essential in situations where toxic exposure is suspected. The medical toxicologist's approach emphasizes collecting collateral history that details the timeline of symptoms, the nature of the patient's workplace, and other processes occurring there alongside the specific job duties. This is particularly important because the relationship between work and health issues may not be immediately discernible, especially with delayed symptom onset. Moreover, inquiries regarding materials used in the workplace, including herbal and dietary supplements, as well as foreign prescription medications that may not be available domestically, are crucial. In terms of decontamination concerning occupational exposures, the relevant principles remain applicable, although methods may vary depending on the exposure route. For pulmonary decontamination, the most crucial first step for inhalational exposures is to remove the victim from the hazardous environment. Treatment typically emphasizes supportive care, which may involve providing supplemental oxygen and, when necessary, ventilatory assistance. In the case of dermal contamination, the primary aim is to inhibit further absorption and local tissue damage by eliminating the harmful substance from the skin. This can be accomplished through dilution and washing, ideally starting immediately after the exposure. Water and soap, or even specific solutions such as 0.5% hypochlorite, may be employed. Water is often the best decontaminating agent for corrosive exposures, and prompt flushing of the affected area is critical. It is paramount to provide personal protective equipment for healthcare workers before initiating any patient decontamination to prevent secondary contamination. Ocular decontamination is also important, requiring that the eyes be flushed with water or saline to rid them of irritants. Although gastrointestinal decontamination methods such as activated charcoal and whole bowel irrigation are primarily relevant in the context of oral overdoses, they are less applicable in typical occupational exposures characterized by inhalation or dermal contact. Nevertheless, if a worker accidentally ingests a workplace toxin, these gastrointestinal decontamination techniques may be considered, taking into account the pharmacokinetic properties of the substance and the elapsed time since ingestion. Occupational toxicology highlights the vast and intricate world of toxins. The principles for assessing and managing occupational poisoning stem from general toxicology, which includes an understanding of the toxicokinetics and toxicodynamics of various substances. Resources from the Agency for Toxic Substances and Disease Registry provide valuable information about different toxic substances that are relevant to both occupational and environmental exposure. Comprehensive texts, such as Goldfrank's Toxicologic Emergencies, detail the dysfunctions of organ systems caused by multiple toxins and apply to overdose situations as well as occupational settings. A fundamental principle in all areas of toxicology is the consideration of a broad differential diagnosis using the available history, physical findings, and laboratory results. Prevention and public health. Additionally, occupational toxicology possesses a significant public health dimension. The importance of recognizing every poisoned worker as an index case is emphasized, as this perspective can help prevent further exposures within the workplace. Clinicians play a critical role in determining whether other workers may be at risk. In some countries, they may also have reporting obligations to relevant governmental agencies. Data regarding occupational fatalities and illnesses reveal the considerable burden of work-related exposure on a global scale. This emphasizes the necessity of implementing effective industrial hygiene practices and regulations to limit or completely eliminate exposure to industrial toxins. In conclusion, occupational toxicology is a crucial aspect of the broader field of toxicology, addressing the unique challenges that arise from workplace exposures. While it shares fundamental principles with general toxicology, it places particular emphasis on inhalation and dermal routes of exposure. Accurate diagnosis requires a detailed occupational history. Decontamination strategies within occupational settings prioritize the removal from exposure source and local decontamination of affected skin or mucous membranes. A solid understanding of occupational toxicology is essential for protecting worker health and preventing work-related illnesses and fatalities. In the field of medical toxicology, it is crucial to comprehend the pharmacokinetics of specific drugs in overdose situations in order to guide decontamination strategies and predict clinical outcomes. This discussion elaborates on information regarding quetiapine, citalopram, escitalopram, venlafaxine, sertraline, and salicylic acid in relation to overdose and decontamination processes. Quetiapine is an atypical antipsychotic notable for its rapid absorption, reaching peak concentrations within 1 to 2 hours after therapeutic dosing. It demonstrates extensive protein binding and a high volume of distribution, ranging from 5 to 14 liters per kilogram. The primary method of elimination is hepatic metabolism through the cytochrome isoenzyme CYP3A4, with subsequent excretion of mainly inactive metabolites via the urine. The clearance of quetiapine can be influenced by drug interactions involving CYP3A4 inhibitors or inducers. In the case of overdose, research has examined the effect of single-dose activated charcoal on the pharmacokinetics of quetiapine. One study, which involved 54 overdose events with a median reported dose of 4,000 milligrams, with a range between 900 and 12,000 milligrams, determined that activated charcoal, when administered at a median of 3 hours after ingestion, ranging from 0.5 to 6 hours, reduced the fraction of quetiapine absorbed by 35%. However, it did not significantly influence its clearance. This indicates that activated charcoal can be effective in limiting further absorption even when given after the traditional 1-hour window post-ingestion. This effectiveness may be attributed to delayed gastric emptying or ongoing dissolution of the drug within the gastrointestinal tract. Additionally, case reports and clinical practice suggest that undissolved quetiapine can remain in the stomach as residual material or pharmacobezoars for prolonged periods, potentially lasting several days after ingestion. Gastroscopy has shown that pharmacobezoar formation occurs in approximately 50% of cases following quetiapine ingestion. These pharmacobezoars, particularly those formed from extended-release formulations, can lead to continued drug absorption and prolonged toxicity. The most effective methods for dissolving these pharmacobezoars continue to be a subject of investigation. A pharmacobezoar should be suspected if there is evidence of ongoing drug absorption despite initial decontamination efforts. Citalopram is a selective serotonin reuptake inhibitor known for its long intrinsic plasma half-life of approximately 41 hours. It is primarily eliminated through hepatic metabolism, which involves specific enzymes such as CYP3A4 and CYP2C19. Population pharmacokinetic and pharmacodynamic modeling studies have evaluated the impact of a treatment known as single-dose activated charcoal, or SDAC, after cases of citalopram overdose. In a study by Freeberg and colleagues that examined 63 instances of citalopram overdose, where the median dose was 270 milligrams with a range from 20 to 1,700 milligrams, it was found that administering 50 grams of single-dose activated charcoal within 4 hours of ingestion in 16 instances was estimated to reduce citalopram bioavailability by 22%. Furthermore, this treatment increased the total body clearance of the drug by 72%. This enhancement in clearance suggests that activated charcoal may serve not only to limit absorption, but also to improve the elimination of citalopram that has already been absorbed, potentially through a mechanism akin to gastrointestinal dialysis. Additionally, a dataset of patients was utilized to assess the hypothesis that single-dose activated charcoal reduces the risk of QT prolongation in cases of citalopram overdose. Comparable studies have also been conducted to investigate the effects of single-dose activated charcoal on escitalopram, which is the S enantiomer of citalopram. Early administration of single-dose activated charcoal following an escitalopram overdose has been estimated to decrease its absorption by 31%. A figure presented in one of the studies illustrates a comparison of predicted individual clearance values for citalopram, both with and without the use of charcoal, alongside values for escitalopram, also in both scenarios. These studies emphasize that while both drugs are influenced by single-dose activated charcoal, the degree of this effect may vary. It is noteworthy that in the study concerning citalopram overdose, all patients who received single-dose activated charcoal were taking citalopram therapeutically, and no other methods of decontamination were employed. Co-ingested drugs that are metabolized by the enzymes CYP3A4 and CYP2C19 were considered for their potential impact on drug clearance, although none were explicitly implicated in pharmacokinetic interactions within this context. Venlafaxine is a serotonin-norepinephrine reuptake inhibitor that has a relatively short plasma half-life of approximately 12.9 hours. However, it is often administered in an extended-release formulation. Recent studies have investigated the effects of single-dose activated charcoal and whole bowel irrigation on the pharmacokinetics of venlafaxine in cases of overdose. One study found that single-dose activated charcoal increased the clearance of venlafaxine by 35%, although it did not have a statistically significant impact on the fraction of the drug absorbed. In contrast, when combined with whole bowel irrigation, single-dose activated charcoal was found to decrease the fraction of venlafaxine that was absorbed by 29%. The study also simulated how these decontamination protocols affected the concentration of venlafaxine over time. While both single-dose activated charcoal alone and the combination of single-dose activated charcoal and whole bowel irrigation reduced the area under the concentration time curve to similar degrees, the combined approach resulted in a significantly larger decrease in peak concentration of the drug. In cases of venlafaxine overdose, peak drug concentration is particularly important for predicting toxic effects such as seizures. Thus, the greater reduction in peak concentration achieved with the combination therapy suggests that it may play a critical role in preventing severe outcomes from substantial venlafaxine overdoses. The mechanical flushing action of whole bowel irrigation is thought to help quickly eliminate undissolved sustained-release granules of venlafaxine from the gastrointestinal tract, while single-dose activated charcoal adsorbs any drug that has been immediately released. Interestingly, when whole bowel irrigation was administered alongside single-dose activated charcoal, the effect of single-dose activated charcoal on clearance was no longer observed. One theory is that polyethylene glycol, which is used in whole bowel irrigation, might compete with ingested drugs for the active adsorption sites on activated charcoal, thereby diminishing its ability to enhance clearance. Another possibility is that whole bowel irrigation could increase the transit time of single-dose activated charcoal through mechanical action, hence reducing its impact on systemic clearance by quickly expelling it from the gastrointestinal tract. These findings indicate that for managing venlafaxine overdose, particularly with large intakes of extended-release formulations, the combination of single-dose activated charcoal and whole bowel irrigation may be the most effective decontamination strategy available for reducing peak concentrations and potentially lowering the risk of significant toxicity. Sertraline, a type of selective serotonin reuptake inhibitor (SSRI), has been studied for its interaction with activated charcoal in cases of overdose. Population pharmacokinetic modeling indicates that administering standard dose activated charcoal shortly after sertraline overdose can lead to a reduction in the drug's absorption by approximately 27%. However, the existing sources do not provide comprehensive information on the pharmacokinetics of sertraline during overdose scenarios. Additionally, they lack details regarding the specific conditions under which the observed reduction in absorption occurs. Salicylic acid, commonly ingested as aspirin, presents unique pharmacokinetic challenges in cases of overdose, particularly with modified release formulations such as enteric-coated aspirin. These formulations are specifically designed for slow and sustained drug delivery, which can result in delayed peak concentrations and prolonged absorption over the course of many hours. Traditional methods of gastrointestinal decontamination, including syrup of ipecac, gastric lavage, and standard activated charcoal, may demonstrate limited efficacy against drugs that persist in the small intestine due to the properties of modified-release formulations. Whole bowel irrigation has been investigated as a potentially more effective intervention for managing these cases. A study comparing whole bowel irrigation with a mixture of charcoal and sorbitol in cases of enteric-coated aspirin overdose found that whole bowel irrigation was superior in reducing peak salicylic acid concentrations as well as overall drug exposure. The mechanical flushing action of whole bowel irrigation aids in the elimination of the drug throughout the gastrointestinal tract, which may help limit prolonged absorption from sustained-release formulations. Historically, aggressive gastrointestinal decontamination following an overdose of modified-release pharmaceuticals has been recommended. This includes the administration of multiple doses of activated charcoal and sorbitol. However, the data supporting this recommendation have been limited. It is also crucial to recognize that multiple-dose charcoal therapy does not enhance the excretion of all drugs. In summary, the pharmacokinetics of these drugs in overdose situations can significantly differ from their therapeutic use, primarily concerning the rate and extent of absorption. Modified-release formulations further complicate this scenario by prolonging absorption. Single-dose activated charcoal has exhibited varying degrees of effectiveness in reducing absorption and, in certain instances, enhancing the clearance of these drugs in overdose, even when it is administered beyond the traditional 1-hour window. Whole bowel irrigation seems particularly beneficial for overdoses involving sustained-release formulations, such as enteric-coated aspirin and possibly extended-release venlafaxine. This method mechanically removes the drug from the gastrointestinal tract and limits prolonged absorption. Clinical decision-making regarding decontamination should take into account the specific drug ingested, its formulation, the time elapsed since ingestion, and the overall clinical presentation of the patient. Consulting with a medical toxicologist or poison control center is often invaluable in these complex situations. In the field of medical toxicology, managing patients who have suffered poisoning frequently involves a process called decontamination, which is designed to limit how much of the toxic substance is absorbed by the body. This area is subject to ongoing debate, with a shift towards more careful and evidence-based practices as opposed to routine and aggressive interventions. Gastrointestinal decontamination has historically been a fundamental element of initial management for oral ingestions. Techniques such as activated charcoal, orogastric lavage, syrup of ipecac, and whole bowel irrigation have been commonly used. However, the effectiveness of these methods in achieving clinically significant outcomes remains disputed, partly because conducting rigorous clinical trials poses challenges. A quick or reflexive response is not advised. Instead, a careful consideration of the specific toxin, its potential benefits, and the associated risks is necessary. That said, for large ingestions of particularly toxic substances, decontamination can be crucial. Guidelines from organizations such as the American Academy of Clinical Toxicology and the European Association of Poison Control Centers generally advocate for less aggressive strategies, although there is still variability in practice depending on the individual case, especially in atypical or severely poisoned patients. One widely used method is activated charcoal, which is an adsorbent with a large surface area that binds to many drugs and poisons within the gastrointestinal tract, thereby reducing their bioavailability. Activated charcoal operates through weak intermolecular forces with non-ionized organic compounds, usually exhibiting more effective binding. The process of adsorption is affected by several factors. The properties of the toxic substance involved, including its molecular weight and ionization, as well as the characteristics of the activated charcoal itself, such as its surface area and pore size. Additionally, the ratio of activated charcoal to the drug, the duration of time since ingestion, and the contents of the gastrointestinal tract also play a role. The most common approach is the use of single-dose activated charcoal, which may be considered within 1 to 2 hours after ingestion of a substance that can be effectively adsorbed. This consideration should be made based on a risk-benefit assessment. While volunteer studies indicate that this method reduces drug absorption, data on clinical outcomes are limited. There are also several relative contraindications to using single-dose activated charcoal. These include situations such as having an unprotected airway, ingesting substances that are poorly absorbed, like metals, alcohols, and corrosives, conditions that worsen because of vomiting or aspiration, as well as intestinal obstruction or perforation. The most frequently observed adverse effect is vomiting, which carries the risk of potential aspiration. Multiple-dose activated charcoal involves administering repeated doses to enhance the elimination of drugs that undergo enterohepatic or enteroenteric recirculation. This method is particularly useful for substances such as theophylline, phenobarbital, and carbamazepine. Whole bowel irrigation, primarily using polyethylene glycoelectrolyte solution, is another technique employed to facilitate the removal of toxins from the gastrointestinal tract. This method is considered for potentially toxic ingestions involving modified-release pharmaceuticals, significant amounts of metals such as iron, lead, and lithium, or large quantities of slowly absorbed toxins that carry high morbidity. Additionally, it can be beneficial for removing drug packets from body packers. When activated charcoal is also indicated, it is usually administered before whole bowel irrigation due to concerns related to desorption. Several contraindications exist for whole bowel irrigation as well, including the absence of an intact gastrointestinal tract, ileus, significant gastrointestinal hemorrhage, unprotected airway, uncontrolled vomiting, and hemodynamic instability that could compromise gastrointestinal function. Although clinical outcome studies for this method are lacking, expert consensus lends support to its use in specific cases. Decontamination beyond the gastrointestinal tract. The principles of decontamination are applicable to exposures through the skin, eyes, and respiratory system. For dermal decontamination, the immediate removal of contaminated clothing is essential, followed by thorough washing with water, soap and water, or a solution of 0.5% hypochlorite. Acting quickly is crucial in this situation. In the case of ophthalmic decontamination, it is necessary to rinse the affected eye or eyes immediately and abundantly with either water or isotonic saline solution. A Morgan lens can be utilized for continuous and effective flushing to ensure comprehensive cleaning of the eye area. When dealing with inhalational exposures, the first step is to remove the affected individual from the contaminated environment and ensure they are taken to fresh air without delay. The role of the medical toxicologist and toxicology resources. Medical toxicologists play a crucial role in evaluating and managing complex or uncertain cases of poisoning. They utilize various resources such as the Agency for Toxic Substances and Disease Registry, the American College of Medical Toxicology, Credible Meds, LiverTox, and the textbook Goldfrank's Toxicologic Emergencies to aid in diagnosis and management of such cases. Occupational toxicology focuses on the adverse health effects related to workplace exposures, typically through inhalation and dermal routes. It is essential to obtain a detailed occupational history. In these instances, when decontaminating in occupational settings, the priority is to remove individuals from the exposure source and to conduct local decontamination, such as irrigation for skin and eyes. Specific attention must be given to certain drugs in the context of overdose. For instance, quetiapine can have modified absorption with the use of activated charcoal. Studies show that this substance can reduce absorption even beyond the first hour, and the formation of pharmacobezoars may lead to prolonged absorption of the drug. In the cases of citalopram and escitalopram, activated charcoal can reduce bioavailability and may increase the clearance of these medications. Venlafaxine demonstrates that activated charcoal can increase clearance as well. The combination of activated charcoal and whole bowel irrigation may be the most effective method for reducing peak concentrations, especially when dealing with extended-release formulations. In early interventions, sertraline shows that the timely use of activated charcoal can effectively reduce absorption. Finally, with salicylic acid, commonly known as aspirin, whole bowel irrigation may be superior to charcoal sorbitol, particularly for enteric-coated formulations due to the sustained absorption characteristics. The decision to utilize any decontamination method requires a careful assessment of the risks and benefits. This assessment must consider the specific toxin involved, the clinical presentation of the case, and the time that has elapsed since the exposure occurred. Consulting with toxicology experts remains invaluable in navigating complex situations effectively.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.